Well, thank you for the intro. My name is Angie Graham. I am actually a professor of nursing at Marshall University. Oh, my thing's gone, just me. I'm actually a professor, but also moonlight because lots of us nurses, we have side hustles, right? So I moonlight as a case manager. I've worked both in the inpatient setting and in the outpatient setting. So I am literally living my best life, working both places, helping both patients and students. So two of my favorite things in the whole wide world. Now, I do live in Appalachia. I live in Huntington, West Virginia, which is a very small town. Go Herd. Go Herd. But mental health, I've, there's definitely been some improvements over the last 10 years as far as resources for mental health, but it is nowhere near where it needs to be. So I'm going to talk about phone calls and 30-day readmissions and how they kind of all come together. So 30-day all-cause readmissions to the hospital, they've been a burden to patients specifically and even to hospitals for years. Patients are they shuffle back through the system, and hospitals are financially penalized, typically at no or usually at no fault of either of the people. Readmissions lead to hospitals being financially penalized. They lead to poor patient satisfaction. They lead to adverse events. They lead to increased costs. Oftentimes, we as nurses, we talk about the discharge process from when the patient is first admitted to the hospital, but we do our best. I work with fantastic nurses and we absolutely do our best to prepare our patients for discharge. But are they truly prepared? Still yet, no. They still struggle. Often education lacks, or there's poor understanding of those discharge instructions, or they just need reassurance. They don't have the confidence to know that I've been told this and this is what I need to do, or they struggle with what they need to do based upon their mental health disorders. So they lack adherence to medication regimens. They lack adherence to their chronic disease regimen. I'm going to talk about a couple of patients. Let me skip over. So to target these readmission deficiencies, I'm going to call them, I started a project to call patients when they were discharged from the hospital. And it's a little bit more than that. It started higher than that. I would originally go into the hospital, and I worked there, so it was easy. And the patients knew me because I also worked with them. But I would sit in on our treatment team meetings and that we had every week with the providers and the patients and the social workers and everyone all together. And I would pitch my program. I would pitch my follow-up phone call. I would go and see the patient when I knew that they were going to be discharged about 48 hours ahead of time. I would make sure that they had my phone number in their phone. I would make sure that they had an appointment reminder on their phone for when I was going to call them. We would decide a good date and time. And even still, I had patients not answer the phone, and that's fine. It is what it is. But I want to talk about Tony, first of all. Tony was my biggest success story, but also not his real name, not his real picture, but just so you can kind of get it. He was my biggest success story. However, he was also my biggest struggle. Tony had schizophrenia. He had stayed in a psychosis cycle for about 6 months. He had been readmitted to the hospital 5 times within that 6 months. And he really, even though he knew me, I had taken care of him multiple times, he still struggled. He was very paranoid. He, again, even with his medications, went in and out of psychosis. So he really definitely struggled. So I went, met with him in the hospital before he was discharged. We set up a date and time to talk. He had my phone number, and guess what? Tony didn't answer the phone. Tony didn't answer the phone. So I left him a voicemail. I've been known to be a little assertive. I left him another voicemail 24 hours later, and he did call me back a couple days after that because he was confused about his medications. So he realized that he needed someone and that help was there. So he did, in the end, reach out. Tony has a very poor social network. He does not have a lot of friends or family. He lives in a complex with other people, and his neighbors would often call the police or call the ambulance to come get him when he was psychotic. So he really needed someone. He really needed someone that he could come to that was going to be non-judgmental, that was not going to be biased against him, that was not going to judge and would listen. And he did say that he got that out of this program. So that was great. I will say, working with Tony, he did get readmitted to the hospital within 30 days, even though we were doing our weekly phone calls. However, the second month, well, second into third month, he stayed out 6 weeks. And then after that, he stayed out almost 3 months. So it worked. The process worked. He said it felt like he had a lifeline. I'm still in somebody's quote. Somebody said that a few minutes ago. He said he felt like he had a lifeline, someone that he could talk to that would help him. I helped him get his, we at the hospital had no meds to bed program at the time. So I helped him get his medications delivered to his house. I helped him get transport to and from his doctor's appointments, things like that, that he normally would have no one to help with. So Tony, Tony was a great success story. Now, I want to talk about Sarah for just a minute. Sarah was a 28-year-old female. She was highly educated. She had major depressive disorder. She had anxiety, horrible anxiety. She had a very supportive family and a very supportive partner. But poor Sarah, she was very apathetic. She was very depressed. She had difficulty getting up out of bed in the morning. She had difficulty taking a shower. She had difficulty with every aspect of her life. She could not hold down a job. She could not make it to that job. So she comes to the inpatient setting, and we follow the same process that we did with Tony. I met with her a couple days before discharge. We set up her time to call. And she actually answered the phone the first time, which was great because that was actually a rare occurrence. And we worked together to make sure she got to her therapy appointments on time, that she was up. I mean, I would call her in the mornings and say, okay, are you up? You know, you've got this, you can do this, you're going to do great today. She just needed that confidence and encouragement she did not normally have. But she had a great support system who helped her get her medications picked up, who helped her get to appointments, something that Tony didn't have. So basically, follow-up phone calls, um, just a weekly check-in process. We've talked about how telehealth, using the phone, is really a simplistic way, and it is. You know, I had a very detailed template that I went through with each patient, and very detailed of what I put in the medical record. You know, all of the patients got a fact sheet. They had suicide hotline numbers, local doctor's office numbers, things like that. I made sure they had something customized with their psychiatrist number on it, with my number on it. Um, so they would have that to be safe as well. The weekly check-in phone call was probably the most enlightening part of the whole process, because in many instances, even though the nurses felt like they had gotten the patients ready for discharge, they didn't have medications when they left the hospital. They had a ride, oftentimes transport to and from appointments, but that ride would show up on the wrong day, would show up on the wrong time, or the patient would have something going on they would have to change, and there was no mechanism for them to contact that transport company to change those dates and times. So we got that all squared away and figured out, and that seemed to help a lot. I wanted to share some stats with you as well, just because they're not, you won't be able to see them, but I can see them, but I can't remember them off the top of my head. So I had 41 patients that I called every week for 6 months, some on different variations of the spectrum. They all had mental health diagnoses. Readmissions for mental health prior to carrying phone calls was almost 24%. Readmissions during the 6 months of the trial, what we call the trial period, was 11%. So we did have some pretty significant improvement. I made 496 phone calls over 6 months time period, to patients, and 113 to others, to patient families, to pharmacies, to hospital social workers, to doctor's office, to transport companies, all that good stuff. So I think in conclusion, sorry. I think in conclusion, connecting with patients via phone call, again, it's very simplistic, but it worked in this instant. You know, I've read the research on how this also helps patients with other chronic diseases, not just mental health, heart failure, COPD, pneumonia, but the mental health population, I've done it with other populations, and doing it with this population was definitely the most difficult from a personal experience. Um, but I do think also coming from a very rural, underserved, especially in regard to mental health where I'm from, these phone calls, they made a huge positive impact on the patients. And the hospital did keep it going on after the trial, which I was very proud of them for doing that, because it is a cost to them, you know, the staffing, the processes, the having people to make the phone calls. That is all a burden, but it does help out when the penalties for readmissions come in. I know that research does show that there's a positive impact to these phone calls, and showing that those post-discharge phone calls, they can reduce hospital readmission rates. In some cases, according to the research and literature, as much as 15%. It was about 12% in my case. But for me, win-win. Win-win. It was a help to the population. It was a help to the hospital. So I got to do all of the things that I love to do, and it was a huge win-win for the hospital and the community. Right. Thanks.